You're listening to Medscape's In Discussion series on secondary hypertension, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Marwah Abdalla. Dr. Abdalla is a cardiologist, cardiac intensivist, educator, and scientist with expertise in hypertension, sleep, and cardiovascular health. She is the Florence Irving Associate Professor of Medicine at Columbia University Medical Center, where she serves as Director of Education for the Cardiac Intensive Care Unit and co-director of the Columbia Hypertension Center. She served on the writing committee for the 2025 American Heart Association, American College of Cardiology, Multi-Society High Blood Pressure Guideline. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Marwah Abdalla. Welcome to the Medscape In Discussion podcast series on secondary hypertension. Today, we're focusing on primary aldosteronism, a common yet under-recognized cause of secondary hypertension. Growing evidence shows that aldosterone excess affects a clinically important proportion of patients with hypertension and is associated with markedly higher cardiovascular risk, yet screening rates remain strikingly low. With recent hypertension guidelines placing greater emphasis on identifying patients at risk, this is a critical moment to revisit how clinicians think about screening, diagnosis, and management of primary aldosteronism, and how we can better translate evidence into everyday practice. First, let me introduce my guest, Dr. Vivek Bhalla. Dr. Bhalla is an associate professor of medicine and nephrology at the Stanford University School of Medicine and the director of the American Heart Association certified Stanford Hypertension Center. Welcome to the Medscape In Discussion Secondary Hypertension podcast.
Thank you for having me, Dr. Abdalla. It's a pleasure to be here.
I'd like to begin by understanding the magnitude of the problem. When you look across patients with hypertension, how common is primary aldosteronism?
Primary aldosteronism is more common than people realize. It is quite common. The estimates are that it's at least 1 in 10 adults with hypertension. If you therefore extrapolate that and say that 1 in 2 adults over the age of 45 have hypertension, we're talking about 1 in 20 individuals that have hypertension. I generally tell patients that by the time they walked from the parking lot to our clinic, they passed somebody with undiagnosed primary aldosteronism. And so 5% of the adult population is a huge, huge number. And so, yes, it is common. And I would say it's more common than people realize. People don't realize how common 5% is. It's on the order of diabetes and chronic kidney disease as far as prevalence, at least in the United States and probably around the world.
So, which patients then should prompt us to think more seriously about screening for primary aldosteronism?
So that depends on who you ask. I think various guideline committees have opined on this question. In the United States, the American Heart Association and American College of Cardiology recommended that if you have stage 2 hypertension or higher, that we should be screening for primary aldosteronism. Other guideline committees around the world, including the European Society of Hypertension / European Society of Cardiology, as well as the Endocrine Society, have recommended screening for primary aldosteronism for all comers with hypertension. And so if you delve into it a little bit further and you think back to the types of patients that we typically think of as having primary aldosteronism, those with high blood pressure plus hypokalemia, whether that hypokalemia is spontaneous or with medication, or patients with a nodule in hypertension, or patients with sleep apnea and hypertension, or a family history of complications of hypertension, plus a diagnosis of hypertension or hypertension, and sort of other clinical features that would suggest a secondary cause. Those are all populations where the rate is higher than 10%. And so it depends who you ask. From a societal point of view, different guideline committees have recommended different levels, but I think all told, we're talking about patients with hypertension as opposed to patients with hypertension plus something as the newest sort of 2025 guideline recommendation. So there are nuances there, but I think overall guideline committees have recognized how common this is and have moved the goalpost as far as who should be screening.
I appreciate that perspective of the different guidelines. Obviously, as a cardiologist, I'm biased here with the AHA-ACC recent hypertension guideline. It definitely puts a structure around exactly what you described. And I think highlighting that even the resistant hypertension, even without hypokalemia, is really, really important, I think is a welcome change. And for me, also thinking about, patients with stroke at a young age who often forget that's another critical, subgroup population. I was really struck by a recent statistic showing that even among patients who clearly meet hypertension guidelines or society guidelines use, screening rates in the US are still very low, under about 2%. So, what do you think is getting in the way of more routine testing?
Very good point, Dr. Abdalla. Screening rates are way below the rate of the condition. I think in terms of what's getting in the way, this has been looked at in various studies as to why we're not screening. I think it does come down to the primary thing is either a lack of recognition of the diagnosis. People aren't thinking about it. And that's why I opened my comments with not only is it common, but it's more common than we think it is. And also, there's probably some diagnostic inertia. That is a difficult thing to measure and to study. But you have to remember that the majority of people with hypertension are not being seen by you or I. They're not being seen in a hypertension specialty center where this is top of mind for us. They're being seen in a clinical setting, either by an advanced practice provider or by a physician in a primary care setting, either internal medicine or family medicine. And those providers have a lot of things on their plate that they have to deal with. They have to deal with the patient's primary reason for being seen. If it's not for a routine medical exam, they have to deal with all sorts of other conditions, which patients with primary aldosteronism will also have: diabetes, kidney disease, cardiovascular disease, all these other things. And so they've got a lot to deal with. And so it may not be top of mind for them. And plus it's something that they have to send a diagnostic test for. So they can't act on it right away. And so I think all of those things are probably reasons that we have poor screening. People aren't thinking about it, or that it's not at the top of the priority list. And so in terms of thinking about how to change that, I think those are probably places where we should start.
So, Dr. Bhalla, once screening makes sense, what's the initial evaluation that clinicians should be doing?
Great question. The initial evaluation is a plasma aldosterone and a plasma renin activity in the morning, full stop. That works for the vast majority of patients. The only contraindication would be being on a case-bearing diuretic. So plasma aldosterone, plasma renin activity in the morning, that is the screening test, full stop.
So, from the field of cardiology, there are a lot of folks on MRAs that we see. And so, one of the things we often find, so we're talking about clinical inertia, right? On the lens that you take. So sometimes it can feel risky for those who are, treating the resistant hypertension. They put in the MRAs. We know that randomized clinical trials show that MRAs can lower systolic blood pressure by 6 to 9 millimeters of mercury. So stopping them can feel a little bit risky. How do you sort of approach that tension in practice, really managing the difficult to control blood pressure while still trying to make a confident diagnosis?
That's a really good point. And I think it highlights, Dr. Abdalla, why we should not be siloed in medicine. Why should we be talking to other specialists? I'm not a cardiologist, right? I'm a nephrologist. And so the point you just made is an excellent one, because it's not something that I think of first off, that the majority of patients that we see in nephrology or we see in a hypertension center aren't already on an MRA, whereas you probably see a much higher rate since the ROUSE trial came out. And that's an excellent point. I would respond by saying that we do know that of the patients who are on an MRA, they are probably not who may have primary aldosteronism, which if you have heart failure, that's even more than the 10% of everybody with hypertension, right?
Yeah.
They probably are a selected, enriched population that have already had a consequence of having primary aldosteronism. But if you look down the line, they probably are not on a sufficient dose of MRA to protect them from the complications or to treat their hypertension, right? So the guideline in heart failure, and correct me if I'm wrong, is a low dose of an MRA for treatment, right? Like the ROUSE trial did not titrate up to blood pressure. And so from a long-term risk-benefit standpoint, it would take stopping an MRA for 6 weeks and then screening, and it would take the role of an advanced practice provider or hopefully an RN to manage their blood pressure with a physician in the interim for those patients who have such hard to control blood pressure, which that low dose of their MRA is protecting them in the meantime, at least partially. And so I would say, though, that treating them, we do know this from Dr. Vaidya and Dr. Hundemer's work now 7-8 years ago Now, the cardiovascular long-term risk of a primary Aldo patient who was treated with an insufficient dose of an MRA is basically equivalent to patients with primary aldosteronism who are not treated. And you only reach the sort of risk profile, lower risk profile of essential hypertensives if you treat with sufficient doses of an MRA. So in the long term, it probably makes sense to do the stutter step of having to wait a month and a half and having potentially a higher rate of blood pressure or interactions with the patient to get their blood pressure down for that month and a half in order to get them screened. That's what I would say. The other alternative is that you could say, well, if I suspect it, right, it's 1 in 10 patients with hypertension and probably more of those with hypertension and heart failure. If I suspect it, why don't I just increase the dose of the MRA to treat it empirically? You may be right, but I think that there are some things that come up in that scenario that I'm not necessarily sure it's the best way forward, particularly because the medicines we currently have in January 2026 are not necessarily side effect free, right? When we go forward. So like let's take the scenario that you just posited. You have a patient with heart failure and you have a patient with hypertension and they're on a low dose of an MRA. So they are theoretically not blocked from the risk of primary aldosteronism for their hypertension and their ongoing heart failure and other cardiovascular and kidney complications. And the paper I'll refer to is the Hundemer et al. Paper from Anvadi's group from 2018, Lancet Diabetes and Endocrinology, right? Which is an excellent publication. If you believe that they need to be on a higher dose of MRA, you could simply empirically, rather than taking them off medicine and screening them, you could increase the dose of the MRA. Then you're saddled with other potential issues of hyperkalemia, which I know cardiologists don't like to deal with, hyponatremia potentially if they're already on a thiazide as well, or rather more commonly if they're already on a thiazide as well, and endocrine side effects of spironolactone at a higher dose than 25 or 50. And so if you do that and they don't have primary aldosteronism, you are running up against side effects that at some point cease to be worth trying to deal with, if it's not the right diagnosis. Also, 2 more nuanced reasons to screen are that it depends on the study and it depends on the patient. But surgery as a treatment for primary aldosteronism may be superior to medical therapy depending on the context. And so you would not be availing yourself of that option if you were to empirically go up on the MRA. And I think the third reason, it's a more nuanced one, is that when other people have to see the patient, if they have a diagnosis of primary aldosteronism, that is a label that I think carries a lot of weight. It's a diagnosis that everybody's heard of, and it's a diagnosis that everybody knows the treatment. Everybody knows it's an MRA. Everybody knows it's an MRA or surgery, right? These are things that people know if they see that diagnosis. And so if you are not the person seeing them, and if they run into a side effect from this higher dose of MRA, guess what the first medicine is that gets stopped? It's the MRA, right? And there isn't a consequence other than they lose out on being, they're MRA deficient from that point forward for a while. And so there's a gap in their treatment that happens if they don't have that primary aldosteronism label. So I know that's more nuanced, but it's something that I personally have seen a decent amount of, that I think it's worth testing, confirming, labeling, and treating as opposed to just treating.
Yeah. So I'd love to hear a little bit more about your center. It's a AHA certified hypertension center. And can you walk us through, how patients are, sent to you, what approach you take, and sort of treatment decisions?
So I really appreciate the opportunity to talk about our center because it's been a labor of love now for over a decade. We kind of opened our doors in 2015 and said, we want to see anybody with complex hypertension. That's mostly resistant or severe hypertension. It's difficult to control hypertension. It also includes patients with labile hypertension. And we kind of envisioned ourselves as a boutique center when we started, in the sense that we would evaluate every patient before we saw them and provide a tailored set of screening tests before we even saw them, so that when the first time they got seen, it would be, a very efficient interaction that was not sending tests that we didn't need to and sending tests that we thought were important before we saw them. And I think with time and with experience, we've realized that there are certain things that you should do and there's certain things you should not do when running a center that gets a lot of referrals. And so we have changed our practice to not send a lot of different secondary hypertension tests in the patients that have difficult to control hypertension or labile hypertension. And we actually have streamlined it to send a renin and aldo, either screening for primary aldosteronism on pretty much everybody sight unseen, just because of how common it is, and it's really streamlined our care. But we started our center with having a patient be seen in the nephrology clinic because we are the ones who started it. But we are the first to refer them out to our multidisciplinary partners for
Mhm.
any number of things, including diagnostic testing or evaluation. That includes for things like sleep apnea, which you see with primary aldosteronism. That includes renovascular disease, which is not our primary topic of conversation today. That includes autonomic neurology. That includes all the diagnostic and treatment folks that get involved in primary aldosteronism. That also includes endocrine. That includes interventional radiology. That includes our surgical colleagues. That also includes our cardiology colleagues for any and all complications of hypertension as well. And so we have tried to be a multidisciplinary center. And so we try to do most of the diagnostic testing within nephrology, but then once we think we know what the diagnosis is, send them out for either further testing or treatment for these other causes. And we've actually seen and appreciated how common primary aldosteronism is, that we're working on a pipeline and a dashboard to kind of keep better track of where people are in this continuum of, screening, confirmatory testing, diagnostic testing, and treatment. We can improve our outcomes, which is something that involves the electronic health record in ways that I didn't know was possible. And getting folks at the hospital involved to help us with that has been a big help.
That's fantastic. So, what sort of the outcome improvements that you see, when you're talking to patients who are going through this workup, what do you tell them that they can expect to see in terms of results?
So with regard to primary aldosteronism, just to give you a encounter. So let's see, we're seeing patients for the first time and they've already had their screening test. And the screening test is a positive screen before we even see them. And we see them the first time, and much of the history suggests a diagnosis of primary aldosteronism, even though we haven't confirmed it or gone further in knowing exactly how we're going to treat it. What we tell patients, or at least what I personally tell patients, I shouldn't speak for my colleagues, is that we're going to make your blood pressure better. I think we have a really good shot at making your blood pressure better. Whether it's going to be medicine that we're going to treat you with, whether it's going to be surgery we're going to treat you with, we're going to get there really soon. And we're going to try to finish the diagnostic odyssey as quickly as possible to get you on the right path and try to give them the lay of the land as to what kind of testing they're going to go through and why we're doing that testing and what it's important for, what it's good for, what it's not good for, and then kind of get them on the train as quickly as possible. But I'm pretty confident that we can improve someone's blood pressure. So I do say that at the beginning, that I really think we're going to be able to make things better and kind of go from there.
Great. So, how do you see emerging therapies, including aldosterone synthase inhibitors, fitting into the future landscape of hypertension, chronic kidney disease, or cardiovascular disease?
It's a great question and a really interesting area. I should say, for full disclosure, that I do consult for one of the companies that makes an aldosterone synthase inhibitor. I think that's important to say out loud when talking about aldosterone synthase inhibitors. But I do think they're going to have a really important role in what we do. I think, when I first started treating patients with primary aldosteronism and I heard about these things coming down the pike of aldosterone synthase inhibitors, my natural instinct was, we already have two medicines out there. We have spironolactone, which is effective, and we have eplerenone, which has fewer side effects. We've kind of covered our bases. We don't really need anything else. Like, that's kind of how I saw it. But I think I have come to understand that the potency of eplerenone is not what we, or probably the way its inventors had thought. And because of that, there's a lane. There's a lane for once a day medicine that does something very similar for patients with primary aldosteronism. So I think aldosterone synthase inhibitors, without the side effects of spironolactone. So I do think that aldosterone synthase inhibitors are going to be helpful. I do think that they will be second line behind MRAs just from a purely access point of view and cost point of view initially. But eventually they will probably supplant the MRAs, probably after the patents, have run out. But I do think that they're going to become quite common. Their role in cardiovascular disease and chronic kidney disease is still untested. But I think for aldosterone in particular, I think if you say 5 to 10 years down the road, what's going to be the most common medicine? I think it's probably going to be an aldosynthase inhibitor once a day. It's potent medication. There are two medicines in the field. There are more coming. I can't see why it won't be top of mind once there are generic versions.
Okay.
And until that time, MRAs will still play a prominent role, but I think they'll be first line soon enough.
Okay. So, last question before we wrap up. I want to bring it back to implementation because we've been touching upon it throughout our conversation. A practice or a health system wants to just start with one or two changes to either improve screening, diagnosis, or management of primary aldosteronism. What would you prioritize first?
I prioritize screening. I think that's our biggest gap.
Mhm.
Right? We have a 98% gap to fill. If you have a patient that has every region in the world to suspect primary aldosteronism, talking like hypertension plus hypokalemia or resistant hypertension or the other criteria we talked about earlier, 100% of those patients need to be screened. 100%, and we're at 2. That's a 98% gap. That is huge. So I would say, and I am not an implementation scientist, and there are colleagues that we have here at Stanford and around the country that are far better at this than we are, and in health systems outside the United States are probably going to be even better than we are here. But whatever is the most effective way of having an EHR alert. I know people have alert fatigue, so health implementation scientists probably know the best way to get things done, whether it's ordering the test for a clinician, as a health system, whatever is the way, using AI to pinpoint which patients would be most likely to require it per guideline recommendations, which a blood pressure above 140 counts, right? I don't think that takes that much AI to do. But implementing screening in that population to improve screening is going to lead to better downstream rates of diagnostic testing and eventually cure or effective treatment. And so I would start with screening.
Okay. So, to end, 3 short key takeaways. What are you telling clinicians?
I would say the first one would be to think about primary aldosteronism early, because a delay in diagnosis is not good for patient care. I would think about primary aldosteronism often based on how common it is. And I think we didn't have time to get into it too much today, but I think aldosterone is likely to be playing a role in cardiovascular and kidney disease beyond just those people with overt primary aldosteronism. So people with milder forms of low renin hypertension or milder forms of an aldo-renin ratio that isn't quite primary aldosteronism, aldosterone is probably playing a role. And so we're going to be using MRAs and aldosynthase inhibitors in a lot more people than we do now.
Fantastic, Dr. Bhalla. Thank you so much for joining us. And thank you to our listeners for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on secondary hypertension. This is Dr. Marwah Abdalla for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Secondary Hypertension podcast series with our host, Dr. Marwah Abdalla. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on secondary hypertension.